Assalamu alaikum and welcome to the Medical Black Book. Our today's topic is
Burns. In this chapter, we will discuss how to treat burns. So, the first step is immediate care of the burn patient. This is divided into the pre-hospital care and hospital care. In the pre-hospital care, we ensure firstly the rescuer safety, stop the burning process, check for injuries, cool the burn wound, give oxygen, and elevate the patient. In the hospital care, we take care of the breathing because whenever a patient inhales the burn product or gases, it results in laryngeal edema. So the patient comes to us with stridor, hoarseness, as well as anxiety. In order to relieve it, we do an endotracheal tube intubation, which is done within 4 to 24 hours. After 48 hours, the laryngeal edema subsides. We can also give steroids to a patient in order to inhibit the inflammation. Then we need to establish a proper breathing. If the patient inhales sufficient amount of smoke, the patient becomes confused or has anxiety, and the inspiratory rate increases, the pulse rate also increases, and the saturation occurs in about 24 hours to 5 days. So, in order to relieve of such anxiety and confusion and respiratory, we perform physiotherapy, nebulize the patient, and give warm humidified oxygen. Metabolic poisoning. It is when fire is caused in an enclosed space and patient um, inhale that carbon product. Now, the patient inhales basically carbon monoxide. Carbon monoxide has high affinity towards hemoglobin, so it mobilizes the oxygen that is bound to it. Similarly, when carbon monoxide binds to it, there is no oxygen provided to the rest of the body. Such patient enters a hypoxic state. In order to avoid such a state, we give such a patient that has been breathing air in enclosed space 100% oxygen for 24 hours in order to mobilize that carbon monoxide that is binding hemoglobin. Similarly, we provide oxygen to the rest of the body. Mechanical blockage to breathing. When there is full thickness burn on the body, ashes are basically formed. Ashes are basically crustaceans. If these are formed after burning. If these are formed all around the circumflex of the chest, this inhibits or constricts the chest movement, resulting in carbon dioxide retention. In order to avoid it, we do scoring cuts that allow the chest wall to easily expand, and hence the patient respires. Now, how do we do assessment of the burn wound? This is done by Lund's and Browder chart. This Now what happens? We divide the body in the rule of 9. Similarly, we calculate all of the burn area into a percentage, and we prioritize them or give them the degrees of basically how much degree of that area has burned. This can be classified amongst first degree burn, second degree burn, and third degree burn. So the percentage that are being given to each of the respective part of the body is approximately 9% is given to the head and neck, 9% is given to the upper arm, 9% to the forearm. Collectively, this makes an 18% upper limb. Similarly, the lower limb is also given an 18%. The leg consists of 9%, the thigh consists of 9%. Only the perineum is given 1%. After calculating all of the percentages, we can give the patient the degree of how much degree of burn has occurred on that respective body. Similarly, respective treatment can be given according to the degree of burn. Now, in the types of burn, if the patient has received a superficial burn or the first degree burn, in such a patient, the burn is no deeper than the papillary dermis. And it is pink, moist, and blanching. Blanching means if we press upon it, the pink color would disappear and become white because the blood supply in that respective area is being stopped. So after removing pressure, that respective area would again become plain. This is known as blanching. In this type of degree of burn, scarring occurs within 2 weeks. The next we have is partial thickness burn or second degree burn. This involves the reticular dermis. There is no blanching and there is fixed capillary staining after 48 hours. Sensation of that respective area is lost, and scarring occurs in that area within 3 weeks or more. Then full thickness burn. In full thickness burn, the whole dermis is involved. And that respective area has a leathery feel and is charred plaqued and has no capillary return, and the respective vessels in that area are thrombosed. Now, whenever a patient is burned, there is a dehydration occurs in that patient because of loss of fluid from the plasma. So, in order to resuscitate a patient having burns, we give them appropriate fluid. Now, when do we start giving fluid? Fluid is given in a child when that child has a percentage of more than 10% of total body surface area is burned. In adults, we start the fluid resuscitation when more than 15% of the total body surface area is involved. We can also give fluid, oral fluid in such patients. That oral fluid should always contain salt. Fluid is calculated by standard formula, and urine output is also monitored in some patients in order to know that patient is properly well perfused or not. Then, how do we give fluid replacement in the first 24 hours in a burn patient? We give them by the formula known as Parkland formula. This states total body surface area into weight multiplied by 4 is equal to the volume that is given in the first 24 hours. Then the types of resuscitation fluid. The first type of fluid is the crystalloid. This consists upon basically drinker lactate. This maintains the intravascular volume. This fluid is less expensive, and because protein leaks out of the burnt capillaries, so hence we do not give colloids first. We give the patient crystalloids first. Now, how is this fluid infused into the patient? If the patient 100 ml is infused in the first 24 hours for 10 kgs of weight, 50 ml is infused for the next 10 kgs, and 20 ml for each kg body weight. This is properly understood by an example. If you have a burn patient having a 70 kgs body weight, so for the first 10 kgs we give the patient 100 ml of fluid. For the next 10 kgs we give them 50 ml of fluid in the first 24 hours. Then what is left is 50 kgs are left. So 50 is multiplied by 20 ml, and the calculated result, all of this is added together, and this is the total amount of the fluid that is administered into the 70 kg man. Now, other types of fluid are hypotonic saline, which consists upon human albumin solution. It produces hyperosmolarity and hyponatremia. The advantage of such fluid, it causes less edema and decreases acherotomies. Acherotomies are basically incisions that are inflicted on the body after the body has been severely burned and charred. These are done in order to in the chest wound. This is done in order so the chest can expand easily, and we also do decrease the intubation if this type of fluid is given. Our next type of fluid is basically colloid resuscitation. In this consists upon plasma proteins. It increases the plasma oncotic pressure because it binds to the oxygen to the fluid that is present in the vessels. It should be given after the first 12 hours. Before this time, there is a massive fluid shift of proteins because in that state, inflammation has occurred and the vessels have become leaky. So even if you give protein, that will all leak out in the tissue, which would attract more water from the plasma, and similarly edema would result. Now, the formula in which this is administered to the patient is described by Muirs and Bartlett, which states approximately 0.5%. 0.5% is multiplied by percentage of body surface area involved times the weight is equal to the one portion of the fluid that is to be administered into that body. Then how do we monitor fluid resuscitation? We monitor this by calculating the urine output, which is approximately 0.5 to 1 ml per kg per body weight. If there is low urine output, infusion rate should be increased. This decrease in infusion rate is shown by the patient by the following signs such as restlessness, tachycardia, cold peripheries, and high hematocrit. The treatment is by giving 10 ml per kg per body weight bolus IV infusion into that patient. Always remember, do not over resuscitate the patient because it is also considered dangerous. and we know this by calculating the urine output, which is more than 2 ml per kg per body weight. Now, how do we treat a burn patient? We know we do acidotomies, which is basically making small cuts on the body so the body can easily expand. We can also give medications respected to deep, superficial, and partial burns. The additional aspect of treatment of the burn patient is by giving them analgesics, energy balance and nutrition, monitoring and control of infection, nursing care, physiotherapy, psychotherapy, surgery for acute burns, and delayed reconstruction and scar management. Acidotomy is done in circumferential full thickness burn. It should be done in the mid-axial line to avoid major nerves. It causes large amount of blood loss, so blood should also be arranged in such a patient. In a full thickness burn, the medications which are given is the first is dressing with non-crystalline silver. The types of crystalline silver that are used are silver sulfur diazine cream 1%, which has broad spectrum prophylactic agent. So this also has an antibacterial property against Pseudomonas aeruginosa and MRSA, which is methacholine resistant Staph aureus. The next cream which we can use on burns are silver nitrate solutions, which is a prophylactic against Pseudomonas colonies, but the disadvantage of such solution is it is not as active as sulfadiazine against gram-negative anaerobes, so wound needs to be re-soaked every 2 to 4 hours. Then we have Mafinide Acetate Cream, which is associated with metabolic acidosis, and silver sulfadiazine and cerium nitrate. The dressing is especially for full thickness burns. It decreases the cell-mediated immune response, and cerium for sterile ushers. This helps to boost up the cell-mediated immunity, which helps in the inflammatory process going on, and similarly it further helps in the wound healing or the burn healing. Now for superficial and partial thickness burns, the medication used are our first aim is to apply dressing that is not too painful, or we use simple exposure. Initial exudate needs to be managed with frequent cleaning with clean linen and Vaseline impregnated gauze on the wound so that the gauze does not adhere to the skin, because while removing such dressing it is very painful. Now, analgesics given in such patients, if there is acute burn and it is large, then we give an intramuscular injection of opiates. It isn't given if there is more than 10% burn because the absorption is unpredictable. In small burns, we give topical cooling agents such as toothpaste. In subacute burn, we give continuous infusion of tablets or slow-releasing morphine. Energy balance and nutrition. Now, in a burn patient, a lot of catabolic activity is being caused in such a patient. So, in order to overcome that, we need to give the patient appropriate nutrition. If the patient is wholly burned and they cannot ingest it, we give them nutrition by an NG tube. This NG tube is passed if the patient is burned more than 15% of the total body surface area. Essential food should be given through the pathway in order to provide the raw material for body's repair. And we also need to remove the burn spot so the catabolism drive is stopped. Now, the next point is monitoring and control of infections. The feeding formula for a proper nutrition balance is by Curry's formula, by the Sutherland formula, by Davis formula, and protein needs. The current formula states when the patient has been burned and is within the age of 10 to 59 years, the food that is administered is 25 multiplied by its weight plus 40% of the total surface area. If the patient is above 60, the feeding formula is 20 times the weight plus 65 times the total surface area. In Sutherland, children should receive approximately 60 kcal energy per kg plus 35 kcal multiplied by total body surface area. In adults, they should receive approximately 20 kcal energy per kg plus 70 kcal % of the total body surface area. In Davis formula, the children should get 3 gram per kg plus 1 gram percent of the total body surface area. In adults, 1 gram per kg plus 3 grams percent of the total body surface area. The protein needs are the great nitrogen loss occurs in the born patient in the first 5 to 10 days. So 20% kilocal energy is required to replenish the lost protein. Then we lastly give the nursing care, appropriate physiotherapy and psychotherapy in such patients. Because this psychotherapy is needed because in burn patients they have been increasingly traumatized, and in order to recover them to appropriate health, psychotherapy is given. Then lastly is surgery. Any burn, whether superficial or deep, unless it is less than 4 centimeters square, needs surgery. Deep thermal burn needs tangential shaving and split skin grafting. Anesthetist needs to maintain good patient control of blood pressure, central venous pressure, clotting time, hemoglobin level, and etc. before starting the surgery. For the burn patient excision of the subcutaneous, we need to inject them with adrenaline and tourniquet for control of blood loss. This injection is given in the subcutaneous area in order to prevent further bleeding to occur when the burnt area is being excised. In a full thickness burn, excision of the skin that is scarred is then covered by skin graft. Because the skin cannot grow over that scarred area, so skin graft is used. In a post-operative management, careful evaluation of fluid balance and level of hemoglobin. Antibacterial, and there is antibacterial dressing of the wound. Delayed reconstruction and scar management. Eyelid should be grafted before exposure keratitis occurs, and burning alopecia is treated by tissue expansion of the unburnt area. Hypertrophic spars respond well to pressure garments worn for about 6 to 18 months, and Z-plasty is done when graft of large area is needed. Non-thermal burns. There are various types. Electrical injury. Electrical injury is first divided into low tension injuries and high tension injuries. In low tension injuries, there is damage to subcutaneous tissue. Because of the alternating current, tetany can be caused, and this can stimulate abnormal cardiac pacing. This can even lead to cardiac arrest. In high tension electrical injuries, can cause a compartment syndrome, resulting in myoglobinuria, which can lead to a renal failure. There can also be severe acidosis, which can be treated by bolus bicarbonate infusion. Chemical injuries has two aspects. It can be physiological destruction of the skin or by poisoning by systemic absorption. Initial management is by copious lavage with water, except for in phosphorus and elemental sodium. When you have injured by an alkali, there is more destruction, whereas in an acid there is only superficial destruction because alkali gets absorbed into that respective area, while acid only stays on that area and destroy it superficially. So for treatment, we give the patient calcium gluconate. If large area is involved, we give them a Beer's block, because Beer's block, what it does, it inhibits the neurons. Similarly, the patient cannot perceive pain. This Beer block also contains calcium gluconate 10% gel, which also has an analgesic effect. If the burn patient is total body surface area acquired is more than 50%, hypocalcemia and subsequent arrhythmia can also result. So, in such a patient with more than 50% of burn, we give them acute early excision of that burn area, and we repair that area by grafting. Then, destruction by ionizing radiation depends upon exposure. Either this exposure of ionizing radiation can be generalized or localized. A lethal dose can affect the GIT mucosa, cause immune system dysfunction. In frostbite injury, what we do treatment of such a patient is by reforming them in a bath at 42 degrees.